Welcome to Live Doctors. I'm Dr. Andrew David Schiller. I'm your host. Today we're sitting together with Dr. Dana Wallace. Dr. Wallace is an expert in allergy and immunology. She's an assistant professor of allergy and immunology at Nova Southeastern University in Florida. She has served on numerous organizations of allergy and immunology and seems to have done a tremendous amount of work creating practice parameters and guidelines, basically helping allergists understand and know what's the cutting-edge research show us about how to understand and diagnose and treat various kinds of allergic conditions. So she's in a great position to talk to all of us about our specific topic today, which is atopic dermatitis. So welcome and thanks very much for joining us.
Thanks very much, and I'm very happy to join you today and to try to share my information on atopic dermatitis.
All right, so why don't we start by defining it? What is atopic dermatitis? It sounds scary to me.
Well, atopic dermatitis is a chronic rash, eczematous reaction. It comes and goes, and it's always associated with intense itch. I think that's really the basic definition.
So an itchy rash, basically.
Mm-hmm.
Yeah. So what kind of challenges or problems does that cause? Is it a serious, dangerous thing? Is it more like a bothersome, inconvenient thing? Is it associated with other bigger problems?
Well, we start with the fact that it starts very early. We know that probably 60% starts in infancy, before that baby is even a year old. And before age 5, 85% have the disease. So it's very troublesome. And this child is scratching, he's uncomfortable, he can't sleep, and just the parents are beside themselves with what to do with this very itchy, crying baby. So it is a very quality of life issue. It is not usually a disease that's going to be associated with death, but it's chronic. We have no cure, but we have very good ways to try and control it. We often see it associated with food allergy in infancy, so the two go hand in hand. In fact, the eczema may start and then food on the skin causes the development of food allergies due to its absorption. So it is a chronic disease. Sometimes it will remit so that at the end of childhood, it's gone in terms of active disease, but it leaves residual behind. You have often spots of white or hypopigmented areas, and it's a little scaly. The skin is just dry to the touch, and tends to get inflamed very easily and susceptible to chemicals. So even when it's not active, it's still a problem. And so again, it's a disease that must be treated throughout life. It is also found in adults as well.
Now, are there particular risk factors, the particular demographic or geographic variables that make someone more likely to have this?
There are. We know that genetics is the basis. And so you start with the genetic pathway. If one parent has atopic dermatitis, there is going to be a twice the risk of that child having atopic dermatitis. If both parents have the disease, it's threefold higher. Now, we know that other allergic diseases such as allergic rhinitis and asthma are often found in the same family members, but they don't carry the same risk as if the parent actually has the atopic disease. And we see this as a disease of westernized countries. So in the US, up to 30% of children and up to 10% of adults will have the disease. If you were to go to, for example, a study was done in Jaipur, India, it's less than 1% of children who had the disease. So there's something about our modern life and the changes that make allergies more prevalent in general, and particularly atopic dermatitis. So you start with genetics, and then you have defective barrier. What we mean is the skin does not protect you against the forces of nature, sunlight exposure, dryness, and soon it starts to break down. Then allergens and scratching do further damage to the skin, advancing the disease. Sometimes it can get secondarily infected. Staph aureus, which I'm sure you've all heard of, can cause a very severe infection. And chickenpox, the herpes simplex, can, if that child is exposed, can cause a very serious life-threatening disease. And so it is a disease that we want to try to keep under good control.
So if I'm hearing you correctly, it sounds like there's kind of a vicious cycle with atopic dermatitis, where the skin, that's the affected skin, sort of breaks down a bit, and that child becomes more susceptible to irritation, other infections, and other complications.
That's correct. We have different areas of involvement. We know that the entire skin is often involved. We know a particular genetic disease is called filaggrin, as a mutation genetically inherited. That skin is very severely affected every place. But we know that any child with eczema will have some involvement of dryness. Then you have what we call acute or very active lesions. And those are the ones that are more susceptible to cracking and oozing and weeping and secondary infection. Then it can go into the chronic phase. So the chronic phase means the skin becomes very thickened, it becomes very plaque-like, it's dry, and it may stay that way and not ever really return to a normal-looking skin. And this is very troublesome, obviously, because it can be disfiguring, it affects the emotions of the child and the adult to have a skin that is not looking nice and feeling nice.
Now, does that can happen any place on the body, or are there particular places where it's more likely to be?
Well, depending upon the age of the child or the adult, it does have areas of the body that are more involved. It will start on the cheek in the young child. Then as soon as they can scratch, it goes on the knees and then on the ankles, the areas that they can reach. Then as you get to be a child, it becomes the inner elbow, behind the knee, the neck. The adult, those areas continue, but now we see the hands and the feet are involved. The hand wife's eczema, sometimes it's called. And we also see the face, around the eyes, around the mouth, and the forehead are involved in the adult. So it does vary based upon age.
Atopic dermatitis, is that the same thing as eczema, or is that a different issue?
Well, eczema is sort of a general word, and you could say that contact dermatitis, meaning you're in contact with an allergen or poison ivy, for example, or a chemical, a cosmetic, and you get a rash, that would be eczema, but that wouldn't be atopic dermatitis. In atopic dermatitis, there's always some allergic type response. Many times it's due to an environmental or food allergen. Dust mite is a very commonly recognized cause, as would be milk, egg, wheat, soy, peanut. Any of those in the very young child might be a responsible factor. But even when you have atopic dermatitis without an allergen, there's allergy cells underneath the skin. So it is an allergic response. In fact, you can develop, many adults do, an allergy to themselves, an autoallergen. So there doesn't even have to be an external allergen. And so technically it is different than eczema itself. It has very distinct characteristics.
Is it associated with other diseases? Do people who have it, are they more likely to get other diseases, autoimmune problems?
We call that the allergic march. And what happens is you start out with atopic dermatitis, and very soon in infancy, if you are going to develop food allergy, it will probably happen. But then up to 75% of those children with atopic dermatitis will go ahead to develop allergic rhinitis. 50% will go ahead to develop asthma. So it covers the spectrum of allergic disease.
And what about later in life? You know, we hear about people who've got serious autoimmune diseases like rheumatoid arthritis or lupus or things like that. Is there a connection there? I mean, they're both kinds of immune reactions, but are they different?
They're not strongly associated. Indeed, that those disease states can overlap, but we don't put a high risk factor on that developing. It's more the ones that I mentioned earlier that we see as very strongly related.
Interesting. Okay. You mentioned before, Dr. Wallace, that there is a hereditary component, and then there's an environmental trigger that can sort of bring this thing out, atopic dermatitis, and cause it to be expressed. What is a parent to do? Is there if a parent has atopic dermatitis or their spouse has it also, are there ways to prevent it? Do we, anything that they should be looking out for to try to prevent it from developing in the child?
I'm happy you asked that, because some of the newest research is suggesting that in that high-risk child, like both parents have atopic dermatitis, and maybe they also have other allergic diseases and dry skin, then the one thing you want to do from the time the child comes home from the hospital at birth is to start protecting that skin. You would want to use emollients, that's moisturizers. Moisturizers without a fragrance or added ingredients, a very gentle kind of pure moisturizer, and there are a list of those that are easily available. And you would want to apply that twice a day. And you would do that indefinitely, basically, because you want to prevent, the infant usually starts out non-allergic in terms of food and environmental allergens. We want to keep it that way. And if we can keep the skin fully normal looking and feeling and moist, we may be able to prevent the development of the disease. That's called primary prevention. That's what we really aim for. So it is very important to recognize. In fact, it wouldn't hurt for every child to do this if we could get parents to do it. So there would be no problem if everyone would do that. And while we're talking about moisturizers, some people confuse a moisturizer and a sealer. Vaseline, for example, is greasy and it feels like it would moisturize. But if the skin is not already damp and soaked, usually for 15 or 20 minutes in a bathtub, then you can pat dry, and then you could put on Vaseline, and then it would help because it would seal in the moisture. But Vaseline, as an example, or any other type of oil, does not add moisture to the skin. So it doesn't do any good to put it on a dry base.
Oh, that's helpful, very interesting to know. So Dr. Wallace, you explained that one of the ways that parents can try to prevent atopic dermatitis if their child's at risk is to use moisturizer to keep the skin healthy and moist and prevent the barrier from breaking down. You mentioned that Vaseline isn't really a moisturizer, it's more of a sealant. The question that comes to mind for me is a lot of commercially available moisturizers have that same ingredient of petroleum distillates that is Vaseline. Are there particular ingredients to use or to avoid in a moisturizer, and are there any particular products that you use in your practice that you feel are best?
Well, you want products that have been studied and that the manufacturer will indicate is adding moisture to the skin. And there's various ways that that can be composed in terms of the structure of the product. When I recommend products, I tell the patient to look for fragrance-free, that's a key word. But two products that I really like is Eucerin. It tends to be a very greasy feeling. Some people don't like that, but it works very well on very dry skin. And Alpha Carry has a product. There's a lot of different products on the market. And if you go to some of the professional websites, like my own American College of Allergy, Asthma, Immunology, you can certainly find a list of what those would be. And of course, the more milder, or the creams, the ones that feel more pleasant, could be used when the skin is looking totally normal. Once you have an acute event in the skin and the eczema is broken down, the skin is broken down, and you have active lesions, then you want a very thick, almost greasy feeling moisturizer such as Eucerin, because it's going to be much more effective on thickened, lichenified, we call it, skin. So we'd recommend that. There's a tip that I often give children and adults who have widespread eczema. Maybe their skin is very dry and cracked and they have just thickening every place. It can be an expensive disease because it takes a lot to cover the entire body. So how do you moisturize when the little bottles come and you may go through half a bottle in one application? So I often ask if they have a bathtub. Most people take showers, but they usually do have a bathtub. And I ask if they will give a soaking bath. And that's going to be about 15 minutes. And then I want them just to pat dry, leaving a layer of water on top. And then I want them to apply a very pure substance. This substance comes in gallon containers, and it's called shortening, like Crisco shortening, like you'd make pies with. Well, then you put that on the body, and it works beautifully. It is a sealant. It seals in the moisture, and it's inexpensive, it's pure, and the patients come back and just say, I can't thank you enough, Dr. Wallace, for giving me that tip. So that's one practical advice that I use. Another practical advice along the same line is many times eczema will become secondarily infected, for example with staph. And you have oozing and you have weeping of the skin, and it's very red and angry looking. And so how do you take care of these recurrent episodes? For the acute ones, you might even need to prescribe an oral antibiotic, but you have identified the patient that is at risk. So I will oftentimes have them to that bath water add like 1/4 to 1/2 cup of Clorox bleach. The Clorox bleach has a very good effect on reducing the colony count of the Staph aureus. And you might do that 2 or 3 times a week. And as the skin improves, maybe less frequent. But to keep that going as a method of controlling the amount of flora can go a long ways, and it's very inexpensive also.
Now, you've talked about some interesting notions of using actually shortening after a bath, Crisco. People come back and thank you. What is it that they notice? Do their skin feels better, or do they get less cracking, scaling lesions? Or?
Well, the treatment of atopic dermatitis is like a pyramid. The base of the pyramid is the emollient, what keeps the skin barrier intact, and that's the moisturizers and the sealants. And so you want that as your first layer of treatment. You stack on top of that then usually a low-strength topical corticosteroid. So that would be your next line of treatment. In very thickened and severe patchy areas, you may have to go to a stronger, a higher class of a corticosteroid for a short period of time. As you improve, you work your way back down the pyramid to where then you only stay on your moisturizers and your sealants. But that's long-term therapy. That's never going to stop because, as we said, we don't cure the disease. We control it. And it's just like high blood pressure. You get it controlled, you're not going to stop taking the pill. You have to continue taking it. Likewise, with atopic dermatitis, you continue to keep that skin barrier normal. If the child continues to itch, you try a second generation, a non-sedating antihistamine. That may help also. Not everyone, but sometimes it will be effective. So you want to prevent the trauma to the skin. You want to keep the skin moist. And then obviously for more severe disease, we sometimes have to go into other agents. Rarely will we use, as we talked about, an oral antibiotic. We might at times use a topical antibiotic such as mupirocin for very isolated areas for a short period of time. And then we also, for very severe short-term use, would be oral steroids. But the message is don't use them long and don't use them often. This is not the appropriate long-term treatment for atopic dermatitis.
So you've mentioned how you don't have any sort of blanket statements about foods that might or might not cause flare-ups, and that is it safe to say that there may be food influences, but it might be very individual, or is that not even an accurate statement?
Well, the foods that I mentioned, the milk, the egg, the wheat, the soy, the peanut, are the ones that our guidelines say in the child less than age 5, if you cannot manage with topical medications, then consider doing allergy testing to determine if there is first sensitization. Then you have to do the challenge of an elimination diet and then a provocation. So you take it out of the diet for 3 or 4 weeks and then you add it back. Being careful to eliminate on a long-term basis only those that you've been able to establish play a role. In the adult, it's usually not recommended that you do that at all, unless the adult says, I know for a fact that this causes a problem. Then I would say don't eat the food. But we don't go testing in the adult for that.
You've talked a bit about how there's a genetic component, and then there's this breakdown of the skin barrier and kind of this vicious cycle where things get worse. Are there other environmental factors that have been identified that can contribute to the child developing atopic dermatitis or things getting worse? You know, a lot of people are interested these days about the effects of stress, the effects of food, diet, other things like that. Are there anything we can put people in line and say, yeah, this is actually very relevant?
Well, the element of stress and food we consider triggers. I don't think we have any evidence that they are the cause of the innate development of atopic dermatitis. So once you have that abnormal skin based on genetics and barrier defects and allergies, then those can be factors that trigger an individual episode, and that indeed is the case. But I don't think it causes it to develop.
So in other words, if I'm hearing correctly, a trigger is something that might bring on a flare-up, but
Correct.
The underlying disease process is still there, and it just flares up in response to the trigger. Are there known triggers? Are there things that parents or adults with parents of children or adults with atopic dermatitis should be just aware of as they're going through life, particular foods, particular environmental? Well,
you know, the food element typically does apply to the child 18 months and below. It's rare that an older child and an adult will have a major food as a trigger. And honestly, it's the opposite that I think is a concern that I have in terms of food. Many times, and I can think of a child that I saw recently in the office who came to me because they knew I had a friend who had done well, and so they came to see me. This was a 4-year-old, had been under the attention of a pediatrician, and at age 2 had some blood tests taken to see if they were allergic. Now, a child with atopic dermatitis many times has a very high potential for allergy. That means an elevated IgE level. And many times when you do blood tests or skin testing, you'll come out with a lot of positive results. The bottom line is that those are not all important in terms of triggering the atopic dermatitis. But the pediatrician had asked this child to stop eating milk, egg, wheat, as well as soy and peanut. So a very restricted diet. The child couldn't go to a birthday party normally and have birthday cake, and was very, very much inhibited. And the child was being treated, every time they would flare, the pediatrician would prescribe oral steroids. So here you have this chubby little child who is now steroid dependent almost, because as soon as you come off the oral steroids, usually it will flare up again. And so the parent thought they were doing the right thing. They had given up on they'd been trying Vaseline on dry skin, and they just gave up putting on those topical steroids because compared to the prednisone, it didn't seem to do anything. So we had a disaster. So working through this case, we first said, let's get it under control. So we started the bottom of that pyramid. Let's start doing moisturizing. And for a very severe child, you might even need to do what we call wet wraps, a wet pajama and then a dry pajama on top of it. And they wear that to bed at night and with moisture, sealing in the moisture in the skin. Then we also started using some moderate strength in bad areas of the topical steroids. Then we titrated down to low strength. Once we got that child controlled, we then said, we're going to try adding foods back. And so we will add back, maybe we start with peanut or with egg, and we will try it for 2 or 3 weeks. If there's no flare, it's probably not important. The child can go back to eating it. So we worked our way through the entire list. Only milk was important. When we re-added milk, we saw that the rash did get worse. So for the next 6 months, the child continued to avoid milk. At the end of that time, we tried it again. And by this time, the child had lost that allergy, now was fully on a normal diet. The mother understood that Vaseline needed to go on if used only when the skin was moisturized. And then the child we didn't cure the child, but the disease was controlled, and the mother understood that the child could have a normal life. So so in terms of foods, it's sometimes felt to be more of a trigger than it is because it's not understood. And of course, that's where the allergist comes in. We need to help those parents sort through these positive tests and this concern. We've already spoken about another tip, and that is everything should be fragrance-free. From the detergent to the fabric softener to the moisturizer, there should be no fragrance in anything. It is a highly irritating substance. Dry skin doesn't need to be exposed to sunlight to the degree that you get sunburn. Elements of excessively dry environments, excessively windy environments can all damage the skin. So you want to protect the skin barrier. So those are some practical things that parents can do. On the other hand, we have absolutely no evidence that taking probiotics, that taking special diets, or that other homeopathic remedies really have any effect in the management of atopic dermatitis. Now, there is some Chinese herbal medicine. People always ask about alternatives that in some studies, in some countries, have shown effect, but the majority have not, particularly in our more westernized countries. So that's not an advice that I would recommend patients do.
So we've heard about a whole sort of pyramid of approaches that doctors use to try to reduce the activity of the disease and to treat the acute flare-ups and quiet things down. What about complementary therapies? A lot of people are curious about that, whether it be things they're putting on the skin, or special foods, or supplements, or homeopathy, acupuncture, Chinese medicine. Any use of those things?
Well, what we know from research is that probiotics, which is a popular approach to treating allergies in general, has not been shown to have any beneficial effect in atopic dermatitis. Special diets and high vitamin intake has likewise not been shown to have benefit. Now, vitamin D may be the exception. We would recommend that if the child or adult has been found to be deficient in vitamin D, that they do receive supplements with that. And a lot of our population in the U.S. is deficient in vitamin D. Now, in terms of complementary medicine and acupuncture, we don't have any good studies to show that that is what we should be recommending. In terms of topical treatment, let's go with what's been shown in research, and that the product has been able to demonstrate benefit from a moisturizer, not just what an expensive cosmetic product advertises that is good for the skin. This may not apply to the atopic dermatitis patient. Herbal Chinese medicine is interesting. In some studies, particularly in Asian countries, it has been shown to benefit at least a subpopulation of atopic dermatitis patients. Usually in the U.S. studies, it's not been so successful, and we don't know which product should be used because there's various components in all these research. There's not a common denominator. So until we have more research studies, I would not recommend that.
What's in the pipeline? Is research promising to show us anything? Is there anything that looks like it might be useful? What would you tell our audience about that?
Well, one thing I would like to share with the audience is that we do have research ongoing in very high-tech kind of products. One is a monoclonal antibody, a humanized, that blocks the interleukin-4 receptor. It's a very complicated process. It's called dupilumab. It's not yet available for treatment, but early research studies is very promising. It seems in adults, where it's been predominantly studied, to reduce about 50% the amount of activity in atopic dermatitis. But of course, this is a very expensive medication. It's administered as an injection on a weekly basis. Again, it doesn't really cure the disease. It's just a very good control for those very severe patients. Likewise, in research, we have a couple of different ointments that are being studied, not as far along as the monoclonal antibody I mentioned, but keep tuned. Perhaps one day we will have a non-steroidal ointment that is more effective at managing the disease state. The more we learn about atopic dermatitis, ideally we'd be able to take a cord blood sample, test it for IgE, test it for a chemical called TARC, test it for filaggrin mutation, identify the high-risk patient, put that into that barrier protection, really intensely work with those children and prevent the development of atopic dermatitis. If we can't do that and the child has already been sensitized, then avoid the allergen when we can. And for example, dust mites, a key one. If that's important, then reduce it from the environment. We are also doing research on immunotherapy, allergy injections for atopic dermatitis. For dust mite, it looks very promising. And again, some clinicians are starting to use it, particularly when there's other disease states such as allergic rhinitis. It may indeed help the atopic dermatitis. Could we, by immunotherapy of one form or another, prevent that allergic march? By treating early the atopic dermatitis, maybe the child would never develop asthma or allergic rhinitis. So that's what the future holds, but we're not quite there yet.
We talked about the connection between genetic and environmental influences on developing this disease of atopic dermatitis. You mentioned stress can be an issue. Is there anything more that can be said about that, both in terms of understanding why stress is part of the problem, and what would a patient or a parent of a child with atopic dermatitis, are there practical things they can do to deal with that stress immune issue?
Stress is important in atopic dermatitis. Again, more as a trigger than as a etiology or a cause of the disease to start with. And it plays a role in quality of life issues for patients. The teenager going to school doesn't want the involvement of the lips with the cracking and the fissuring. That's very unappealing, doesn't look nice. They're embarrassed. How can they go to the prom with this? And so they want their skin to be really looking nice. So we have to work with them and effectively show them how to manage the disease. When you have a patient who is excessively stressed and they scratch, it's called the itch-scratch cycle. And eczema has often been said to be the itch that rashes. So we have to break that cycle. And that's hard to do with the patient who's very stressed because they just keep scratching and scratching and scratching. And so we try to use medications to assist them. Sometimes they may indeed have an underlying anxiety disorder or other disorder, and we can use the psychiatrist and the psychologist to help manage some of those patients who are intensely dealing with stressful issues. But all in all, we try to improve the skin so that their quality of life can be better, and thereby we reduce the stress that they're facing.
Interesting. Are there any effects of exercise that's been shown? Because in other diseases, it seems like people who get regular aerobic exercises generates chemistry, it relaxes them. Has anyone looked at that in this disease state?
I'm not aware of anyone looking at exercise in terms of a beneficial factor. We have to advise some of our patients to exercise in an air-conditioned environment and try to reduce sweating, because sweating is one factor that actually makes eczema much worse. And patients are very uncomfortable with this, so they may select a sport such as swimming, where they don't sweat so much. So exercise in many ways can be detrimental. I'm really not aware of any research that shows a very positive beneficial effect.
Okay. Thank you so much for joining Live Doctors. I'm your host, Dr. Andrew David Schiller, and we've been here with Dr. Dana Wallace, who's an expert in allergy and immunology, learning about atopic dermatitis. Thanks for joining us, and we look forward to seeing you again. Thanks, Dr. Wallace.
Thank you.